non-surgical tumors. I'm going to give a slight introduction, assessment, general management, and pain management. Kill me or cut my lower half. This is a word that I heard and I will never forget when I graduated from medical school and started my career in general surgery at that time. I heard that patient who was crying and saying, kill me or cut my lower half, because he has cancer and he has very severe pain. At that time, we couldn't give him any medication, and after 2 weeks, the patient died in misery. And here's the question: opioid leads to addiction. Is that true? A lady called Pitcher, who had a trauma in her spine, and to treat her pain, she has to be on opioid. She said, I've never been high from morphine, nor has she ever been tempted to take more than the prescribed amount. But she says she's worried of becoming addicted. She's not the only one with that fear. Addiction is widely used by physician and patient and everybody, but many people don't use it accurately. Addiction is far more than just craving. It means also negative consequences in social life and job. Tolerance and dependence are not the same as addiction. So this is my just first introduction to this talk. Spine is the third most common site for cancer cell metastasis, followed by liver and lung. Approximately 30 to 70% of patients with primary cancer have positive spine metastasis in autopsy. Only 14% will have symptoms. And here's how patients have a problem of metastasis and tumor in spine, either in the vertebra or in the spine itself, spinal cord, or epidural tumor, or cord compression due to prolapse or fracture, and leptomeningeal tumor. All this not necessarily to be treated surgically. Therefore, we have to diagnose the cause to give the appropriate treatment. The most common site is thoracic spine, then lumbosacral, then cervical. Most common tumor that metastasize to spine are lung, breast, GI, prostate, and lymphoma. The major presenting symptoms of tumor is local radicular pain, motor weakness, sensory loss, loss of sphincter control. Pain is the starting symptoms and is consequently followed by neurological symptoms. So the first thing that happens to our patient is pain. Symptoms suggestive of spinal metastasis means that there is metastasis, not necessarily cord compression, pain in the thoracic or cervical spine, progressive lumbar spine pain, severe and remitting lumbar spine pain, spinal pain aggravated by straining, localized spine tenderness, and nocturnal spine pain that prevents sleep. Symptoms suggestive of spine metastasis with cord compression, radicular pain, limb weakness, difficulty of walking, sensory loss, bladder and bowel dysfunction, and on examination sign of spinal cord or coda equina compression. In the assessment, we have to differentiate, we have to take full history to see if there is any neuropathic component of pain or somatic component. Usually with spine metastasis, you will have both somatic, that is likely bony pain or muscular pain, plus neuropathic type of pain. It is important to do MRI for diagnosis and to exclude cord compression because it is very important. The timeline for doing MRI is 1 week in patient with symptoms suggestive of spinal metastasis, the first set of symptoms that I have mentioned. 24 hours if there is any symptom suggestive of cord compression, like neurological deficit. Sooner if emergency treatment is needed right now. If MRI is contraindicated, then we have to do to consider myelography, tomography, bone scan in order to make diagnosis. Patient may receive one or combination of the treatment as a general management. First of all, pain control, steroid administration, radiotherapy, chemotherapy, and surgery, including non-invasive procedures. Non-surgical tumor, we mean by that spinal metastasis with no cord compression. Patient is not fit for surgery, or there is cord compression with late presentation. Dexamethasone is important to treat pain to start with, and also to prevent some neurological consequences that is related to cord compression. But if there is no cord compression, still it is valid because it reduces pain. It is used as adjuvant. Radiotherapy also is considered for treatment of cord compression as well as for relieving pain, and it is very effective, and it is the most intervention that may be used in non-surgical tumor. And the goal is to reduce tumor size, relieve pain, prevent progression of neurological deficit, and prevent recurrence. I'll skip this one in regard of chemotherapy because of time. Then you'll do your general palliative care like pain symptom management, emotional management, need for consider spiritual need, family support, rehabilitation, discharge planning, and assessment for hospice admission in case if it is needed. The treatment will be according to WHO, by mouth, by clock, by letter, for the individual, and attention to details. So whenever the patient is able to take oral, treat the patient orally. If not, then you can use alternative route. By the clock, because the pain is so severe, you have to treat the pain around the clock and to start with short acting every 4 hours. And if there is any breakthrough pain, that is a pain in the middle, regardless of the regular dose, you can start or give a PRN to cover that pain, which is very important. And most of the time it is forgotten. By ladder, you start by non-opioid plus or minus adjuvant, then weak opioid, then you can consider strong opioid like morphine and other strong opioid, plus or minus adjuvant. And adjuvant can be NSAID, anti-steroid, and muscle relaxant. For individuals, the right dose for opioid is the dose that relieve pain for that individual. The dose can be 100, can be 20 milligram. So this is for individuals, and there is no ceiling effect for opioid. And you have to pay attention to details with very clear, accurate prescription. These are the opioids that are used: morphine, oxycodone, hydromorphone, and codeine, methadone. I think this is more details, but the starting dose of morphine is 5 milligram per oral with short-acting PRN every 1 hour. The PRN is every 1 hour. The regular short-acting is every 4 hours. And you give the PRN every 1 hour as needed. Then you will titrate the patient. After 24 hours, you see how much the patient took from the regular plus PRN. Then you titrate the dose accordingly. You submit all and provide that dose. Okay. Thank you so much.